Yeah. We'll have a conversation.
Mr. Chairman, your next bill is SB 1076.
Sorry, Madam Chair.
No problem.
Stephanie was flirting with me. Madam Chair and members, this bill is intended to address problems associated with a growing trend of patients being treated under observation status for extended periods of time. Often patients are not even aware that they have not been admitted to the hospital, even when they've been moved outside of the emergency room into a hospital bed and kept overnight or longer. Additionally, there is a lack of data on observation service utilization, which leaves policymakers with a lack of information on how often and for what reason outpatient observation services are used. This bill does three things. It requires hospitals to provide notice to patients who have been placed on observation status that they are receiving services as an outpatient and that this may affect insurance reimbursement. Secondly, it requires if observation services are provided in a dedicated unit that it is neither the emergency room nor part of the normal inpatient beds, that this unit abide by emergency department staffing requirements and be marked with a signage identifying the unit as an outpatient area. And thirdly, requires hospitals to report observation services to the Office of Statewide Health Planning and Development. And with that, members, I respectfully ask for an aye vote. I have individuals that are here to testify in support of the measure. Yeah, and I do have authors' amendments that are being passed out, which reflect the agreement reached with the California Hospital Association these agreements tighten the definition of observation services.
Sorry. Supporters' testimony, please.
Madam Chair, members of the committee, Stephanie Roberson on behalf of the California Nurses Association, proud sponsor of the chair's bill, SB 1076. As you have heard from the chairman, more and more hospitals are placing patients who cannot safely be discharged to their homes in observation status as an alternative to hospital admission. In these settings, patients are sometimes placed for prolonged periods of time. Many times patients are not aware that they are in this observation status, leaving them to believe that they are inpatients, especially when they are in inpatient areas. This is especially concerning for patients who may need to be discharged to a long-term care facility, as Medicare requires patients to be admitted as inpatients for 3 days before coverage for long-term care will kick in. However, time in observation does not count as observation units or observation services. Members, this bill allows us to improve on the already existing federal requirement of notice. If we can get this information in the hands of patients sooner so they aren't surprised when the case manager at a long-term care facility tells them that Medicare won't pay and they have to pay out of pocket, they can be prepared for that situation. There are other elements in the bill, as the chairman has laid out, such as data collection, staffing, and such. But I will defer the rest of my time to David Welch, a nurse at Enloe Medical Center and a board member for our organization, so you can see from his perspective in his work every day. Thank you.
Madam Chairman, members of the committee, I'm impressed that you're staying awake all of this time. Your endurance is amazing. I've been a registered nurse for 35 years working with cardiac patients. For most of that time, the use of observation status in most hospitals was what a reasonable person might expect it to be. There were patients where we needed a little more time to decide whether the problem they presented with was worthy of admission. We needed to hold them for a few more hours to see how they responded to initial treatment or wait for a test result to come back. Space in the ER was tight. ER gurneys aren't very comfortable, so we'd put them in a hospital room but not actually admit them. Observation status. But as a kind of perverse response to recent federal incentives, we believe we're seeing a dramatic upward trend in the use of observation. More patients, sicker patients, patients on observation for longer periods of time, and in a lot of cases, the creation of specialized observation units where patients look like they're hospitalized, feel like they're hospitalized, but because they're not officially admitted, are under a lower level of regulation and at a lower level of staffing, essentially an unregulated level of staffing in most cases. Besides these safety concerns, many patients' insurance may not reimburse as well for outpatient care as they do for inpatient. So again, the patient, even though they look and feel like a hospital patient, may be subject to copays that they aren't expecting and that they wouldn't have on an inpatient basis. The biggest issue of all for a lot of our patients, as Stephanie's already alluded to, has to do with what happens when they leave the hospital. With ever shorter hospital stays, a significant proportion of the elderly patients that I see are deemed ready to leave acute hospital care at a stage in their recovery where they're not really ready to be home. 20 years ago, they would have stayed in the hospital until they were truly ready to go home. Now they go for a bridge stay in a skilled nursing facility, but Medicare only pays for that stay if the patient's had a 3-day stay as an admitted inpatient in an acute hospital. So it's all too common for patients to be caught in a bind, told it's time for them to be discharged, not yet ready to function safely at home, but with no Medicare reimbursement for skilled nursing care. Anecdotally, I'm also hearing stories from my colleagues at bigger chain hospitals of patients who ought to be on much higher levels of care being inappropriately placed in observation units in ways that endanger patient safety. And here we come to something that's an important part of the issue, where I said anecdotally. And it's an important part of our bill. Much of what we know about this, or we think we know about it, is anecdotal. What we nurses see for ourselves and hear from our colleagues. There's too little clear data on this, and that's why an important component of the bill is the reporting requirement. As the use of observation status seems to us to be exploding, we think it's important to have the data to really know what is happening. And we think it's entirely fair that patients placed on observation status be informed that they are on that status and what that may mean to them in terms of their care and its costs. The things the bill asks for are pretty basic, that patients be clearly informed on their observation status and what that means, that they have a safe level of staffing while they're in the hospital, and that the regulators and policymakers be given better data about the use of this practice so we all know what is happening. So thank you for your attention.
Thank you.
Madam Chair, members, Sarah Flox, California Labor Federation, and we are also in support of the bill for the reasons outlined. Thank you.
Thank you. Any other support?
Yes, Madam Chair and members, Dolores Duran Flores with the California School Employees Association. We're also here in support of this bill.
Thank you. Any other support? Any opposition?
Madam Chair, just a point of clarification, Connie Delgado with the California Hospital Association. After many years discussing the issues around observation, CHA is pleased to remove our opposition, and we are neutral on the bill.
Madam Chair, members, Tim Madden with the California chapter of the American College of Emergency Physicians. CalASEP had taken an opposed position on the introduced version of the bill with the amendments that the Senator outlined. We're reviewing it right now. It's my feeling that it takes care of our concerns, so I want to thank the author and his staff and the sponsors for their work on this one. Thank you.
Mr. Chairman, members, Tenant Theo Pejos, representing Tenant Hospitals. We have 13 hospitals throughout the state. First of all, I'd like to say we totally agree with both the sponsor and the author as to the problem. And in terms of the bill, what the bill is attempting to do is actually very laudable. We think those are good goals. This is something we've been working on for years. In fact, we've been working with the author staff on this for years, which resulted in the Senate Joint Resolution, which you all voted for, except for you, Vice Chairman Nguyen. Just because she wasn't here. She wasn't here yet.
Wow.
She voted against it.
Just called me out.
She was here. She was here. Look, the point is, patients should know, but here's the point. This has been hoisted upon hospitals. We have not chosen to put people into observation status. This has essentially been a decision of the federal government. Tenet does not put people in these so-called observation units. We put everybody in an inpatient setting where they get full nursing services and all the services that a regular admitted patient would get. We just take less money. So we are essentially a victim just like the patients. Additionally, we already give notice to the patients. The problem that we have with the bill is actually pretty technical, and it's that the nature of the disclosure that is mandated in the bill. What the disclosure says is that you will notify the patient that they're being put into an outpatient setting, or they're being provided care on an outpatient basis. We put all of ours in an inpatient setting. So by telling them they're in an outpatient setting, you're just confusing the patient more. Secondly, the bill talks about differences in reimbursement. We think that language should be different in payment, because it doesn't matter what the hospital's reimbursed, it matters what the patient is paying out of pocket. Again, one other thing on the notice, it talks about Medi-Cal. Medi-Cal does not recognize observation. It always pays the full inpatient freight, so that part of the disclosure shouldn't be even in that portion of the bill. Lastly, as it relates to the reporting of the data, we hope to also work with the author and the sponsors on that. The way that the bill is set up, it actually would require duplicative and more reporting than is necessary. We do agree there needs to be more transparency, but that section, again, needs some work. So again, we agree with the goals here, but the way it's been written would be onerous and would conflict with the type of care that we're providing, which I think you would all want us to provide the care the way we are. So for those reasons, we remain opposed, but we hope to work on this with the sponsor and the author and get this fixed in appropriations. Thank you.
Senator Mitchell?
Quick question. The point you made about the notice in the bill would be confusing to your patients, and I'm not following, since what you do is actually have them in an official inpatient capacity. Why would you be required to give this notice at all?
That's a good question, because the way the bill, the way that we talk about outpatient means you haven't been admitted.
Okay.
Okay, so the federal government is not allowing us to actually admit them. They're in this weird state, whatever you want to call it. Some people call it observations, maybe you call it somewhere in between. We put them inpatient, but now the bill requires us to tell them they're an outpatient. Well, they're not. They're not an inpatient.
So you've created a different kind of in-between space, but you refer to it and treat it as if they're inpatient in terms of them having access to all the services, nursing ratios, all that.
We don't know what else to do. So yes, we do treat them like that. And the definition of whether they're admitted or not is essentially been dictated by CMS and Medicare. And we're in a real bad spot. And that's why this House passed that resolution urging Congress to change these rules.
And so with the definition, as the bill is proposed to be amended, and further defining what they mean by an observation unit,
it becomes circular. It becomes circular. Yeah.
Do you want to respond?
I was just talking to, sorry.
Yeah. She says, how do you fix it?
I think I can answer it. So look, we just need to change the notice requirement. So we are required to notice the patient that they're now being put into observation, and that could potentially change their payment, because it has impacts depending on the plan, right? But we do not think we should say that they're being provided care on an outpatient basis. They need to talk to their doctor about the care that's being received, because it may not be on an outpatient basis. In ours, it's like it's on an inpatient basis. It's just the wording, and it can be worked out.
And does that apply to more facilities than?
I believe so. I'd like to say that there's probably both populations, but we do all of ours and inpatient.
Okay.
If you want to.
It's our understanding that Tenet's the only system that does this, so that's why we developed this definition, but I do agree. I think there's probably something we can work out. I just don't know what that looks like yet, but I think we could probably tweak something, and I think we're open to looking at that down the line if that works. He'll fix it.
Thank you. Senator Monning?
Yes, thank you, and just briefly, appreciate the author's leadership here, and I have a Tenet hospital in my district in San Luis Obispo. I've read the copy of the letter submitted by Tenet, and you outlined the concerns, and I think that letter also indicates CMS is developing notice requirements and a concern of having to do double notice. So I hope there'll be just further conversation. It sounds like some technical wordsmithing that could resolve some of these, but I will be supportive of the bill and appreciate your being here today. Thank you.
Thank you. Any other opposition? Hearing none, is there a motion? There's a motion. Mr. Chairman, would you like to close?
Respectfully ask when I vote.
Thank you. And this motion is do pass as amended to appropriations?
Hernandez? Hernandez, aye. Nguyen?
No.
Nguyen, no. Hall? Hall, aye. Mitchell? Mitchell, aye. Monning? Monning, aye. Nielsen? Nielsen, aye. Pan? Pan, aye. Roth? Roth, aye. Wolk? Wolk, aye. Thank you.
Okay, we're going to go ahead and lift the call. We're going to start off, consent first? We're going to start off with consent item number 10, number 11, and number 13. Call the absent members.
Hall? Hall, aye. Mitchell? Mitchell, aye. Nielsen? Nielsen, aye. 9-0, it's out.
9-0, those bills are out. We're going to start off with item number 1, SB 877. Call the absent members.
Nguyen?
No. I'm sorry. Yeah, I can't, yeah, it's no now since I can't abstain it now. Sorry. Go ahead, no.
No?
Nguyen, no. Hall? Hall, aye. Mitchell? Mitchell, aye. Nielsen? Nielsen, no. 7-2.
7-2, that bill is out. Item number 2, SB 977. Call the absent members.
Nguyen? Nguyen, aye. Hall? Hall, aye. Mitchell? Mitchell, aye. Roth? Roth, aye. 9-0.
9, that bill is out. Item number 3, SB 997. Call the absent members.
Nguyen? Hall? Hall, aye. Mitchell? Mitchell, aye. Roth? Roth, aye.
7-1, and that bill is out. Item number 4, SB 999. Call the absent members.
Nguyen? Mitchell? Mitchell, aye.
7-1, and that bill is out. Item number 5, SB 1010. Call the absent members.
It's already out.
Oh, okay. Item number 6 is out as well. Item number 7, SB 1095. Call the absent members.
Nielsen? Nielsen? Nielsen, aye. Wolk? Wolk, aye.
9-0, that bill is out. Item number 8, SB 1139. Call the absent members.
Nguyen?
No.
Nguyen, no. Mitchell? Aye. Mitchell, aye.
7-2, and that bill is out. Item number 9, SB 1237. Call the absent members. 1273.
Nguyen?
Aye.
Nguyen, aye. Hall? Hall, aye. Mitchell? Aye. Mitchell, aye. Monning?
Eight to 0, that bill is out. Item number 12, SB 1401. Call the absent members.
Hall? Hall? Hall, aye. Mitchell? Aye. Mitchell, aye. Nielsen? Nielsen, aye.
9-0, that bill is out. Item number 14, SCR 117. Call the absent members.
Nielsen? Nielsen, aye. Wolk? Wolk, aye.
And that concludes the business of the day, and we are adjourned.